All right, hi everyone. Welcome to today's session of Healthy Discussions. Before we get started, just a few housekeeping notes. The chat feature is open for conversation and questions, so feel free to use that. You can turn on subtitles for this webinar. They are auto-generated, but you can do that by clicking the CC button on the bottom left corner of your screen. And this session is being recorded and will be posted to Quality of Care NL's YouTube channel in the coming days. I'd like to acknowledge that we're joining you from the ancestral territory of the Beothuk, and the lands on which Memorial University's campuses are situated are in the traditional territories of diverse Indigenous groups. We acknowledge with respect the histories and cultures of the Beothuk, Mi'kmaq, Innu, and Inuit of this province. We invite everyone to offer land or territorial acknowledgements in the chat and to take a moment to reflect not only on why we offer these acknowledgements, but also ways your life and work may contribute to decolonization and reconciliation. For those of you who aren't familiar with Quality of Care NL, we are a research and evaluation program based at Memorial University aimed at improving social and health outcomes in our province. Healthy Discussions is a webinar series where we have quality conversations about health, healthcare, and social systems in Newfoundland and Labrador. Our goal is to engage with you on these topics with the aim of continuing public conversations during the ongoing process of health transformation in our province. Public discussion also contributes to the growth of a learning, health, and social system in Newfoundland and Labrador. On the screen right now, you can see a definition of a learning, health, and social system as defined by Health Accord NL in its task force report. This definition might seem a bit complicated the first time you read it, but what it really boils down to is a health and social system that continuously improves through a culture of best practice, evaluation, equity, openness, and collaboration. The system learns and gets better, resulting in better care and health for everybody. Part of the definition states that individuals and families are active participants in all elements. By engaging in sessions like this one, by being an active participant in your own health care and wellness, by talking about and acting on issues that impact us as a society, you are contributing to a learning, health, and social system. So today's topic, our discussion is going to focus on the practice of midwifery. And we're very pleased to have joining us today Brianna Thompson, who is the province's chief midwife, and Sarah Donnelly Harnum, who is president of the Association of Midwives of Newfoundland and Labrador. Joining them for today's discussion is Chelsea McPhee, who is one of our colleagues from NL Support. Chelsea works in patient and public engagement and capacity development. And Chelsea has some questions to get our conversation started, but I just want to let the audience know that we will be taking questions throughout. So you can go ahead and type those in the chat as they come up, and we'll stop every now and then to check in with the audience Q&A. So I'm going to go ahead and stop sharing these slides, and Chelsea, you can get started with our discussion.
So much, Melissa. So our first question is for you, Brianna, if that's okay. We thought maybe it would be a good place to start if you could tell us a little bit about the practice of midwifery and for example, what are midwives trained to do as it relates to the care that they provide.
Sure. So midwifery is a regulated autonomous health profession, and they specialize in providing comprehensive care to individuals throughout pregnancy, birth, and the postpartum period. They're highly trained clinicians, educated in normal birth and reproductive care, but also able to identify when complications arise. And they work really collaboratively within the health system to ensure clients are receiving appropriate care. They're primary care providers. So similar to when family physicians also do maternity care, they manage prenatal care, attend the births, but we attend births in hospitals, homes, we can work in birth centers. And then we provide postpartum care for both the birthing parent and the baby for up to 6 weeks after the birth. And really there's a focus on culturally safe, trauma-informed, client-centered care. So they're excellent clinicians. They're skilled in all those assessments, prescribing medications, ordering, interpreting tests, conducting emergency procedures when they need to. But just as importantly as all of that, the midwives are also really focused on building trusting relationships with their clients, which we know improves health outcomes, particularly in underserved or rural communities. So really important in terms of health equity. So ultimately, we do perinatal, reproductive, and newborn care, but midwifery is really about promoting choice and continuity and respectful care, and having that influence in the health system.
Yeah, thanks for that, Brianna. You know, I come from a province where midwifery is really entrenched, and even just preparing for this session, I learned more about the scope of practice of midwives and midwifery in Newfoundland and Labrador. So it's been interesting. Sarah, our next question is for you. So for a birthing parent who decides to choose midwifery, what could their experience look like as they go through the stages of pregnancy, labor, birth, and postpartum care?
I hope you can hear me because I'm still having a lot of technical difficulties. Just wanted to expand a little bit on what Brianna had said before. Midwives across Canada, in line with our National Association of Regulatory Council, are also providing more and more care in different contexts. In Carbonear, we provide PAP and sexually transmitted infection testing and contraception counseling and prescribing, IUD insertions. Other areas in Canada might provide postpartum care and early discharge from the hospital. In my hometown of Hamilton, there's a clinic that's dedicated to IUD insertions and medical termination of pregnancy. And research tells us that midwifery care reduces maternal morbidity and mortality, and that this effect increases when you involve family planning. So I just wanted to add that in. So for someone who is opting for midwifery care, then they can expect appointments to occur at the same intervals as they would have had with any other care provider, and the offer of the same tests and ultrasounds that they would have had with another care provider. We do have the luxury of time built into our model. It's not something that other care providers are afforded. It gives midwives time to have informed choice discussions about any of the things that we're offering to somebody, whether it's an anatomy scan or testing for gestational diabetes. We always have a conversation about risks and benefits, what happens if they choose not to do these things, why we do them, and what happens if something comes back that was unexpected, that was outside of normal. It also gives us time to have education, to provide a lot of education. So for example, in pregnancy, we have discussions about testing medication for the newborn after they're delivered, so that they have time to ask questions about that when they're not dealing with just having had a baby and that baby now maybe yelling at all of us. We also discuss emergencies such as shoulder dystocia and interventions like assisted vaginal delivery in advance, so that people know that that's a possibility, because the reality is it's a possibility for a lot of folks, and that our C-section rate is around 1 in 4 to 1 in 3, depending on where you are. Sometimes it's a little bit higher than that. And so we like to have those discussions ahead of time so that people have the opportunity to ask questions in a non-emergent atmosphere. During labor, we tend to provide a lot of support. So we tend to be there quite a lot, especially during an unmedicated labor and birth. We use a lot of position changes, non-pharmacological therapies such as touch and movement to provide comfort, but also to facilitate delivery, because ultimately the best way of getting someone to not be in pain from labor is to have them have their babies. So we want to sort of expedite that process in however we can. It doesn't preclude people choosing things like epidurals or nitrous oxide or any of those things. Certainly those are all still options for midwifery clients. But if someone is really hoping not to have medications in labor, then sort of our tool bag of non-pharmacological supports is really helpful to them. During the postpartum, we provide primary care to both parent and child. So that includes vitals for both. So blood pressure, heart rate, respiratory rate, temperature, checking the evolution of the uterus. So as it reduces back to its pre-pregnancy size, we watch bleeding. And we look after both for 6 weeks postpartum. We also provide care to folks who haven't been in midwifery care for their pregnancy and delivery here in Carbonear, but don't have a primary care provider for the postpartum period. We also provide a lot of breastfeeding support. So that's another thing that we discuss in the antepartum period or the prenatal period. There's a movement across the province to do antenatal colostrum collection, which is the first milk that is available to a baby. And so that's something that we're going to be seeing province-wide, and that's something that we're very much in support of. We're on call for our clients 24 hours a day, 7 days a week. We also offer home birth to low-risk individuals who are having a healthy pregnancy and live within close proximity to our delivering site. And our research in Canada demonstrates that this is a reasonable option for well-screened individuals. Midwives keep up to date with guidelines from the Society of Obstetricians and Gynecologists of Canada and from our midwifery associations, and we always work to provide evidence-based care. And we are required to maintain certain competencies on an ongoing basis, like basic life support, newborn resuscitation, fetal health surveillance, and emergency skills. So that would be walking into a home birth and potentially seeing a foot hanging out of somebody and knowing what to do. So those are things that we have to keep abreast of continuously because we never know when they're going to present. Pregnancy is not predictable. Labor and delivery are certainly not predictable. And so we have to keep abreast of all of the things that are happening as things change, which they always do in medicine as we learn more and more. We're lifelong learners and we attend as many training opportunities as we can. And we've had a couple of reports out of Gander, which was the first site to have midwifery care that demonstrated almost 100% satisfaction rating with midwifery care, as well as some data that we've collected from Carboneer regarding sexual and reproductive health care that is also showing the same results.
Such a comprehensive answer to that question, Sarah, and it dove into some of the questions that we had planned later on, but I actually, in follow-up to that, I have a couple of things that you touched on that piqued my curiosity. One of the questions we had for you was about folks give birth and the difference between midwifery services and that kind of choice about where birth happens, and your comment just then about pregnancy being unpredictable. I wonder if you could speak a little bit to, whether that choice about where people give birth and how that differs if a midwife is involved. Oh, sorry, Sarah, you're muted.
In terms of how we manage the unpredictability of things in different environments, or?
Yeah, I mean that, but also just in general, in an uncomplicated pregnancy, can midwifery clients then choose where they give birth? Brianna, you touched a little bit on maybe some of the different birth locations, but I wonder if you could just expand on that a little bit.
Yeah, so people can deliver at Carboneer General with our practice if they're in Gander or James Payton Memorial is their delivering site. But people who want to have a home birth are welcome to have a home birth if they are a low risk person having a healthy pregnancy. So if we do end up attending a home birth, we usually have a prenatal appointment sort of close to term, so sort of around 36, 37 weeks, so that we can see where we set up all of our gear, because we usually set up a newborn resuscitation area. We are able to intubate babies at home. We're also able to place umbilical vein catheters, so for basic resuscitation. And we like to see where we can park and how we reach people. And if we had to transport, how would we get somebody out of the house? So we usually set that up. And then when we come into the house, there's a bunch of equipment that supplies that the client would have in the house. So glue pads and things like that, basically stuff to keep tidy, but also IV supplies. If somebody's GPS positive, we can do an IV at home and we can provide them the penicillin G that they would need for prophylaxis of GBS. And then we also carry a bunch of equipment ourselves, which includes like a suction machine for the baby if there's a lot of secretions, oxygen tanks for both parent and child, a lot of instruments for the delivery itself, and then for any repair that needs to happen afterwards, because that's also something that we can take care of at home, provided it's not involving structures around the rectum. So there's a lot of things that we can do at home that are consistent with what's in hospital. The big difference between a home and hospital birth is that we have a low threshold for transport from a home birth because we know that there aren't the resources there if something does go sideways. So if something seems to be trending that way, we make tracks if we can at all.
Helpful information. And I know this is a little bit off script, but again, just something that came up for me as you were speaking and answering that first question. And, Brianna, feel free to chime in as well. But you mentioned about breastfeeding support, and my own breastfeeding experience here in Newfoundland was really positive, actually, with the breastfeeding support and provided by the public health system here. And again, I mean, I'm in Eastern urban, so maybe there are differences across the province as that relates. But I'm just wondering what kind of if there's any collaboration with the public health nurses on that regard and with Baby Friendly and L and that kind of thing.
Yes, absolutely. So I'm one of the board members for Baby Friendly NL. I'm also a lactation consultant, but we work very closely with public health. So we will see people at home usually within the first week to 2 weeks, provided that they're close enough that we're able to do that geographically. Otherwise, we rely on public health to do those initial visits and to make sure that everything is going well with parent and child. And if they need to reach a primary care provider, they can. And we're also on call for those clients 24 hours a day, 7 days a week. So if we have somebody who's got complex social issues or has had a difficult delivery, then we work very closely with public health and will often fill each other in on our last appointment, how things went, how big the baby was, anything that public health needs to keep an eye out for, and they'll do the same for us, so that we'll basically share that person pretty evenly and communicate frequently about what's going on with them so that they get the best possible care from both of us.
So that's so helpful. And, I have to say that those home visits, in my experience, were crucial to breastfeeding success. Actually, wouldn't have been successful for me without that home visit. And sounds like that kind of collaboration and sharing of the caseload is certainly going in the right direction in terms of improving breastfeeding success for parents. So
public health is a very strong entity here, and we're very grateful that they are here.
Yeah, for sure. Brianna, did you have anything you wanted to add on to that?
No, that was great. I think it is different you mentioned your experiences in the urban region. It is different in every zone. Thinking about, Lab Grenfell, they have one lactation consultant and they're not based in Happy Valley Goose Bay. And I think it just kind of highlights the importance of having midwifery, who, all midwives have a lot of experience providing breastfeeding support, lactation consultant or not, they all have experience to support new parents with breast or chest feeding. So having midwives is definitely a way to enhance access to those services and be able to collaborate. So yeah.
Thanks for the reminder of the inclusive language. That's a good reminder. Melissa, do we have any questions coming in through the Q&A?
No, the chat's a little quiet so far. So if anybody has any questions for our speakers, you can feel free to type those in the chat. If you'd prefer to do something more anonymously, you can direct message me and I'll share your question without, mentioning your name. That's easy enough to do as well. But otherwise, I think we can move on, Chelsea.
That's good. Actually, there's a good question. Nice segue here, Brianna, for you, if you don't mind, about, back to this idea of collaborating with other health providers. So how do midwives and physicians, such as family doctors, obstetricians, and specialists work together? And let's say you have somebody whose care ends up needing to be transferred to a physician. Can a midwife then remain on the care team in those cases? And how does that work?
Good question. So it's important that midwives are a part of the team. So they're a really integral part of the perinatal care team. And collaboration is really the key to safe, effective, high quality care. So it's important that midwives are a part of it. Midwives are trained to deal with typically the healthy, the low risk, but increasingly more complex people as our population becomes more complex as well. And we're trained to recognize when additional expertise are needed. And that could be, prenatally, we could refer to a hematologist, we could refer to an endocrinologist. It depends what the situation is. But we know when to consult and when to transfer care to physicians when complications arise. Things can happen at any stage of a person's care, but where medical conditions develop, something like, or even preterm labor or high blood pressure, the need for a cesarean birth, care can be transferred to an obstetrician, but that doesn't mean that the midwife will step away. And it depends where they work, what it will look like next. But often the midwife will, at the very least, remain involved to provide emotional support, continuity, advocacy, depending on the clinical situation and the family's preferences. But they could also be receiving the newborn at that C-section, acting as the baby provider. They might be scrubbing in as a first assist at the C-section. It really depends, and it's contextual, and it depends on the midwife's training and the site's needs. But this really, collaborative approach ensures that clients are getting that right care, right time from the right provider. But we really work hard to preserve that relationship and that trust and the really personalized support that midwifery care is known for. So we don't just leave, but we chip in where we can once we do involve other providers.
So does parent preference play a role as well, I'm assuming? Yeah.
Sorry?
I said, does parent preference play a
Yeah,
role in those kinds of positions as well?
Yeah, it could be that another scenario could be that they found out at their 12-week scan they're having twins. And now they're going to have a lot of surveillance, a lot of appointments, and maybe that's a lot for them and they don't want to double up, or they're being cared for in a different community and we aren't able to see them in person anymore. Totally depends on the situation, but it's always a client's choice who their care provider is. But I find most people, they do want that continued support. Kind of depends on where in their pregnancy things pop up, because as Sarah mentioned too, we have those long appointments. We really do connect with people and become their, the person that they are able to ask all their questions to and get all the information from. So to lose that feels really tricky for most people. So we try to continue supporting, and usually, at least in the case of a cesarean birth, that person might be in the care of the obstetrician for 24 hours after delivery, and then they come back to our care. So it's good to be involved throughout, not step away and then pop up again. The continuity is really important for the quality of care and the collaboration, and really just making sure that it's client-centered always, whatever that means for that client. Yeah, they may decide that they've got enough appointments and they've got enough support. But typically I find, most people are keen to keep their midwives for that extra that midwifery provides, especially postpartum.
Yeah, that's not surprising. I mean, especially speaking to that, trusting relationship piece, and it takes time to build that with folks. And if you're, vulnerable, you're vulnerable in that state. And so certainly that would play a big role, I can imagine. And I know prior to, this move to more access to midwifery in the province, a lot of folks here with the ability to do so would employ a doula. And so I'm wondering if you could, maybe Sarah, you could expand on the differences between doula services and midwifery services.
Yeah, so doulas are labor support folks. Sometimes they're postpartum support folks. So there's different kinds of doulas that provide different roles. We know from a lot of research that having a doula means that you're less likely to opt for something like an epidural, and that you're more likely to be satisfied with your experience at the end of it all. Doulas answer a lot of questions. They're usually very knowledgeable about what's going on in the context of a delivery, so they can fill in gaps if folks are needing more information. Midwives are primary care providers, so we have the ability to admit and discharge and run tests and respond to results and things like that, things that Brianna had mentioned at the beginning of this webinar, which doulas are unable to do, right? It's a very different training system, and we're regulated healthcare providers, where doulas are private support people. But we do work closely with doulas, and we actually had a lovely meeting not that long ago with the doula collective of Newfoundland and Labrador, with some of the doulas that came out here to Carbonear to have a conversation with us about working together and what that might look like. So it was really nice to connect with some of those folks. I wish that doulas were funded in some way, because I think they can be really important to somebody who's perhaps had experiences within a hospital environment. Maybe they lost somebody and it makes them really frightened to go into a hospital. It helps a lot to have that person who's with you and is likely come with you from home, that is sort of that anchor in that storm of anxiety.
Yeah, that's a really good point, Sarah. And I don't, if my memory serves, I do think that the doula collective has some, maybe a bit of funding set aside or some way to query if you can't afford the services of a doula. But I imagine without, you know, a broader funding base for that their ability to actually provide those services free of charge is probably limited. So that's good, really good point.
Mm-hmm.
I do see a question coming in from the chat here. So the question is, the care and support for home birth is great. I don't think I knew this is an option in Newfoundland and Labrador. Is this service exclusive to midwifery? And is midwifery the main support for this?
Yes, to all of those questions. Home birth is offered where midwives are, and midwives are the only ones who offer that service now. It used to be that family physicians used to go into people's homes, but that's really stopped being the case in a lot of areas. So that is something that's particular to our profession now.
The
Jesse,
question
I
is,
had another question come in actually.
yeah, go ahead, Melissa.
Someone is curious about the education pathways that someone would take to become a midwife.
And I actually just gave a presentation on this the other day. There are a number of pathways in Canada. One is the university stream, attending a midwifery education program, an MEP as we call it. There are 6 across Canada, none in Atlantic Canada. So our closest English program is in Ontario. That another stream is for our internationally educated midwives. So someone who already has midwifery training, who has already practiced midwifery, and then has come to Canada and wants to bridge to the Canadian context. We have 2 bridging programs, 3, but in Ontario is probably the closest one and the most relevant to us, where there's a lot of assessment, because obviously midwifery looks really different in different parts of the world. For some, it's maybe a 1-month add-on to their nursing degree. In another place, maybe they only have ever worked in the hospital and haven't done prenatal and postpartum care. So it really depends on what their needs are. So there's a lot of assessments that go into that pathway and then they try to tailor the bridging, but it does have to be close enough to the Canadian context to be eligible to do that bridging. Otherwise, they would be more appropriate for the university stream to do a more comprehensive program. And then third, we have our Indigenous midwifery programs that are community-based, Indigenous-led. We have our own in Newfoundland and Labrador, which is very exciting. The first of its kind, really, in Atlantic Canada, is our Innu Roundtable Secretariat in Labrador. So they're actually just in their 3rd year now, and they have 4 student midwives who are entering their 4th year, and it's a Innu-led, community-based Indigenous program to bring midwifery and bring birth back to community, particularly Shashashi and Natoshish is the goal right now. So that's a very exciting pathway that's available. That's really the only way to become a midwife right now in Atlantic Canada. Is very exciting, and I think there'll be lots of opportunities for collaboration and support from our NLHS midwives and our IRT midwives, and it's very exciting. So there's really generally those 3 distinct pathways. There's technically another one too within the MEP. It would be an accelerated degree. So someone who has been working as a nurse and worked in labor and delivery and has a lot of that labor and delivery experience in a nursing degree might be eligible to do an accelerated program that maybe is 2 or 3 years, depending on their needs and how many of their credits transfer. So that's a bit of an expedited pathway to becoming a midwife if you're already a health professional who has labor and delivery experience.
So thanks, Brianna. And Melissa, I see you've shared some links in the chat, so that's wonderful. Yeah, I wonder if you can expand a little bit on that Innu midwifery program. I think, again, just my own personal interest, and I think a lot of even though maybe there's not a pathway here in the province yet, aside from that, probably there'll be a lot of learnings from that program if and when one becomes developed here in the province, around generational sharing and that kind of thing, and how we hand knowledge down about this practice of midwifery. So, Brianna, I wonder if you could just talk a little bit about where, the ask for that kind of came from, and how it's going so far beyond the graduates that you mentioned.
It's a totally community-driven initiative. It actually kind of spurred from a certain midwife a certain woman really wanting a tent birth, and really wanting to become a midwife, and they managed to do it. She did have, I think it was 2020, where she had a tent birth, and the program really started getting its footing in terms of, you have to find access to funding, and there is federal funding for things like this right now. They're really trying to work towards the truth and reconciliation, and this bringing birth back and bringing Indigenous midwifery back is a big part of that. So the program started getting funding, started creating its own pathway. We have our National Council of Indigenous Midwives, who do support different communities to try to get things off the ground. They provide a lot of resources, but it's obviously so contextual. So this is specifically driven by the Innu, for the Innu in an Innu community, and they hired a coordinator to start building the program. And it is a little bit, iterative. Like you don't start out with a 4-year program written down and then apply for approval and then start it, right? So they're just in their first year and doing all the things that a first-year program in the MEP might do, but with an additional layer of really trying to have their culture included and make sure that it's culturally appropriate, and even the way it's taught, that it's culturally appropriate. And then they graduated their first year as birth workers. So, making it a laddered program where if someone only did 1 year, well, they can still work as a birth worker in their community, and we can still retain that workforce and that knowledge to support birth in Sheshatshiu and Natwashish. So now they've just finished the second year, and hopefully they're going to be getting to do more clinical work soon. But they have been all over the world presenting, because it's a really big deal, and what they've managed to accomplish is quite incredible. And they're in Europe right now. They just presented in Copenhagen. The students went to Hawaii and presented just all about how they're reclaiming birth in their community. And it's incredible to see these 4 young people just being such leaders and taking on not just a midwifery education, which is a really big deal, but the responsibility and the additional work that comes with being an Indigenous program and being like community leaders right off the bat, and being leaders all over the world already. It's quite amazing. It's very exciting. And hopefully, I know that program, their goal is to be able to write the national exam, which will qualify them to really register anywhere. So it's always in development, but they're doing such a great job of collaborating with all of the parties that they need to, working with NLHS to be able to do placements. That's underway, because that's very important that they're able to do clinical work with midwives. And collaborating with the CMRE and the CMRC. The people who decide who can write the national exam policy will have to change. So they're really blazing the trail as they go, and it's just, they're a real force. And I have been lucky enough to be on their steering committee for the last few years, and just getting to witness what they're doing. And it's amazing. It's really exciting to see. They'll probably be for sure will be our first midwives that were made in Newfoundland and Labrador.
That's excellent. And I think your point about context is super important, because you're right. It'll be a really interesting model, I think, and there'll be some learnings from that, collaborative model and partnership with the IRT, for example, the Innu Roundtable, that could be applied elsewhere. And I'm thinking, specifically maybe up in the Nunatsiavut communities, thinking about access and things in those more northern areas. But certainly the context piece is really important as well, and will change depending on the communities that folks are working in and with, right? But maybe that's a pin for us, Melissa, to once the students are back, we'll have to maybe bring them in for a healthy discussion in the future.
Definitely. They're wonderful to hear speak, and there's so much passion, and it's just really exciting. I would highly recommend.
Are there any other questions coming in through the Q&A, Melissa?
Yeah, someone asked, how does one go about getting a midwife? Does the patient have to ask? Is it a service provided by the province automatically? How can somebody, I guess this probably ties in good to a question we wanted to ask, where in the province can you access midwifery services? But how does someone go about getting involved with a midwife?
Midwives are self-referral. So we acknowledge their right to choose their care provider right off the bat by allowing them to call us and ask us for care. So if they're interested in having care, they can either call, if they're in the Gander area or the Central Health area, they can call the office at 3 Bell Place, which is 651-6489, or they can get care in Carbonear or the Carbonear area by calling 945-5517, or they can email Central Health Midwifery, or they can email Carbonear Midwifery to access one of the midwives, and they can call Carbonear for, like I said, a PAP or STI testing and treatment, or an IUD or contraception, or they can call us if they're pregnant and they're interested in midwifery care, and we would go through an intake form with them and then book their intake visit. And depending on what has been done already, we would start off with making sure that the appropriate labs and ultrasounds have been offered to that person, and go over any results if they've already had them, start their care pathway.
Sarah, just to reiterate and maybe follow up on that, I do think you touched on this earlier, but in terms of timelines, because I think in obstetrical care, you still would be hopefully followed by some sort of primary care provider for the first, few weeks of your pregnancy, for example. I think it's at the 20-week mark then that you go or thereabouts, so you would end up seeing your obstetrician. So is it the same kind of timeline with midwifery? No.
So people, often what we tell people is that as soon as you have the stick in your hand, the phone should be in the other hand. Because we tend to have wait lists. In Ontario, we used to say we turned away about 40% of the people that wanted us. I know Gander has wait lists for, I think, every month except for 2. So we get people at 4 weeks. We get people sometimes who realize that there are midwives in their area a little bit later on in pregnancy, and so they'll contact us later on. Generally, you start seeing an OB around 28 weeks, but we'll see people from the very beginning right up until they're almost ready to have babies. And unfortunately, the only places right now to have midwifery services are in Carbonear or Gander, but there is hiring happening for St. John's and also for Happy Valley Goose Bay, Labrador. And eventually, I think it's the plan to come to Western as well. I'm not sure where in the timeline that would be. That would be more a question for Brianna. But currently, there's just the 2 sites. So.
Clarification, and I think that's useful, and also the correction to my time obstetrician timeline. I appreciate that. And again,
what happens in pregnancy? Pregnancy brain is a memorable phenomenon. We've all had it. I'm not sure I'm out of it yet. 20 years on, but whatever.
Yeah, I'm trying to figure out when I can, how far I can stretch that excuse of the pregnancy and parent brain, but.
You can stretch it as far as perimenopause takes over.
There you go. Perfect. I like it. I like that. And I know, again, I think we touched on this a little bit, but maybe just for the sake of being clear, and Brianna, maybe you want to field this one to start. With midwifery care, do parents then still have access to the same kinds of tests, screening options, medications? So thinking about things like epidurals, for example, that they would if they were to choose an obstetrician instead.
Yeah, so definitely. And we've kind of that's been threaded throughout, but I can reiterate. So clients who choose midwives have access to the full range of standard tests, screenings, and medical options available within the health system. So this includes ultrasounds, blood work, genetic screening, and all the way to pain relief options like epidurals, which Sarah had mentioned earlier, because we work within the same evidence-based guidelines as other maternity or perinatal care providers. So we collaborate closely with obstetricians, with family docs, with nurses, anesthesia. So it's really not, when you think about midwifery, it's not distinguished by a difference in access. It's more, there's an emphasis on informed choice and that shared decision making. We just spend a lot of time explaining all of those options that are available, but we will go through them and support people to make the decision that's right for them, and just really ensuring that they're feeling really informed and really, respected and heard throughout their care. So whether they're planning an unmedicated home birth or want a hospital birth with an epidural, maybe they're having an induction, midwives are there to provide safe, supportive care all the way through, but just always making sure that people understand all of those options and that they've truly agreed to all of those options. So it's something that can get lost in our system a little bit, not realizing that we have choice. But they have all the access. It's just they get to learn a lot about it and then be a real shared decision maker and the primary decision maker in their care, which is a really great start to parenting. It's very empowering.
I agree. And I know, Sarah, you mentioned about maybe a bit of an expanded toolkit when it comes to the process of labor and delivery and pain management and that kind of thing. So I think that's certainly attractive to people who are going through that.
Chelsea, I had one quick follow-up to our question earlier when we talked about self-referral to midwifery services. They were wondering if anybody experiencing a pregnancy can request a midwife, or do you need to meet certain requirements? So for example, if you end up having probably a higher risk pregnancy, and I know we kind of touched on this a little bit earlier, but from the get-go, are there certain requirements or questions that a midwifery service would ask of a client before taking them on?
Yeah, there are. So in our intake form, we'll ask about medical history. We'll ask what medication someone has been on. We'll ask if they've had deliveries, what happened in those deliveries. We always encourage people to call and ask, even if they've been told by another care provider that they're quote unquote higher risk. We still encourage them to call us up because they may still fall within the scope of midwifery practice with somebody else involved. So if they've been told that they're higher risk because they have hypothyroidism, we would just collaborate with someone who would manage their thyroid medications throughout pregnancy. So it doesn't risk them out of midwifery care. So I always encourage them to call anyways. And we'll go through the options. We'll go through their medical history and medication history and their obstetrical history, and then get a sense. And there are people who are more appropriately followed by obstetricians, and we will advise them if that's the case. But generally, we can at least start off with folks. And then if at some point something is in the context of pregnancy, then we pivot and carry on from there.
Perfect. It's good to know that you can still always reach out and at least have initial conversations with a midwife and explore it a little bit to determine if it's the right path for you.
And there's that opportunity that we talked about earlier about that kind of not shared care, but just collaboration, because sometimes when people are more high risk, they are more complex for more than one reason and really would benefit from having midwifery care and can't get necessarily what they need from their obstetric care, just given the way our system works with shorter appointments and the frequency is there and they're getting great clinical care. But sometimes it's the emotional and the supportive and the information that gets a bit lost. So there is a role always for midwives, I would say, but it always depends on capacity. They'll have a caseload. They can only do so much, can't be involved in every single person's care. But it's also kind of one of the benefits of our funding model that they're employees, so they can provide that support within their capacity. They can provide that supportive role without it being, in a fee-for-service type model. It's kind of a double dipping and you can't, but there's so much opportunity for collaboration with midwives to support those more complex clients, because really they're often the ones who need midwives the most and need that information and need that support.
Thank you so much. I do see one other question in the chat, Chelsea, if that's okay.
Yeah, no worries.
Where can somebody go to get information on perhaps the accelerated program or bridging programs, or finding out if the credits or the experience or background that they have are relevant or would be accepted in Canada? Where can they go to learn more about that?
It
Open
will
it to Letty.
depend. I could jump. It'll depend on what you're coming from. So if you are a practicing health professional in Canada, you've got that, the nursing degree, you're still applying for the midwifery education program. And then so you have to get in, and then that's where you get to determine whether or not you're kind of eligible for that accelerated stream, because there are only a certain number of folks who will be. So it is difficult. You could probably look at the MEP's requirements and see how many, but it depends how long it's been, where you got that education. It would be a little bit tricky to say for sure. Usually those assessments are happening once you're in the program and you're submitting all of your documentation to see what transfers. In terms of the internationally educated midwives, that assessment is happening by the bridging program, and each bridging program has quite a rigorous process. Nobody else will be able to tell you whether or not you are eligible, no matter where you've worked. We can't guarantee. If you've only ever worked in the hospital, for example, that is really different than primary care provider midwifery in Canada. So the internationally educated midwives would need to apply to the bridging program, and they would conduct their assessment looking at your prior learning, prior experience, to determine whether you're eligible for that bridging. That makes sense.
Perfect.
And
Okay.
I just wanted to say too that North America is a bit of an odd duck when it comes to midwifery, that the majority of the world's children are born into the hands of a midwife. So it tends to be more of like maybe 80% midwifery births and then 20% obstetrics, whereas we're kind of the opposite of that. So it is more common elsewhere in the world. So there are a lot of folks that come from other areas. And when I first joined the Association of Midwives of Newfoundland and Labrador, I was surprised to find that most of the voices on the other end were British, because a lot of our midwives came from England.
Right. Yeah. So still a lot of work to do to kind of build up the practice in Canada and North America generally, I imagine. But good to know that we're finally getting a good start here in Newfoundland and Labrador. And Sarah, you shared a link in the chat just now for the Canadian Midwives Association. Probably could be a good place to start if you have questions and want to ask some more information about being able to become a midwife in Canada.
Yeah, thank you for that. I opened it up here and I see it's the list of places that you can go for that kind of training. So certainly, I'm sure if you had questions about a specific program, you could probably reach out to the relevant program contacts. And again, I think we've kind of been talking around this, but maybe it's worth making it very explicit. Are these services covered by the province's MCP program?
Yes, they are. They are absolutely covered by MCP, so there is no cost to the person coming into care.
Great to know that explicitly.
Yes, yeah, that's how it is across the country.
It'll be nice, and now once it expands a little bit more, and that the practice grows in the province, I think you've highlighted a lot of really important benefits that come from this way of working, and the collaboration that midwives are able to provide with other healthcare providers, for example, can only be a benefit, I think, to people here. So it's something I'm really passionate about. So I was glad that my shoulder was tapped on for this, and also glad to get to learn a little bit more about how things have progressed since I was making my own birth plan. So I appreciate it. I think that was the end of the questions that we had thought to ask you, and my own questions that have come up for me as you both were talking and kindly sharing about this with us today. I don't know, Melissa, if anything else has come through in the Q&A.
I don't see anything else in the chat, but this would be your last chance to chime in with a question or a comment or anything at all in the chat. And I know we definitely have talked about where services are available in Newfoundland and Labrador right now, but I wonder if Brianna, as the province's chief midwife, you could touch a little bit on plans for the continued rollout. And let's say, I know we talked about we're actively hiring in St. John's and Happy Valley Goose Bay, was it? But what about Western Newfoundland, let's say?
Yes. So overall, in the grand scheme of things, Newfoundland and Labrador is still pretty early in its journey of regulated midwifery when we look across Canada. There are others who are not as far along as us, but some who have had midwives for 30 years. So, you know, we got regulations 2016. I came to Gander in 2019 to be part of that first little practice of 4 midwives. And it took several years to get to expansion. It's pretty tricky during COVID. We, started services in 2020. COVID hit. There was definitely a bit of a stall in that moment. But then we were able to do a lot of advocacy with Health Accord NL that happened. And we actually have a call to action in our Health Accord NL. Action 33 calls for newer enhanced programs in midwifery and reproductive health. So I came into this role in 2022, and the first thing that we got to do was like, what's next? Now people were ready to kind of get back to business after surviving COVID. And we developed a 5-year plan and budget that actually was approved the 2023-24 budget year. So we've got a 5-year plan and budget that's been approved that's essentially where we are now, is executing that 5-year plan. So the goal is to have midwifery services in all 5 of our health zones in a staged rollout, because, recruitment is actually extremely challenging for all health professions right now, but particularly it's challenging for midwifery when we don't have, we're not making our own, and we're not making our own anywhere near Newfoundland and Labrador. So the goal is, though, that 5-year plan is to have, we went from 4 in 2022, we should go to 20 by 2027, 28, and have midwifery services, have teams in each zone providing care. So right now it started in Gander, it expanded to Carbonear, it's in the works in Labrador, and it might be a bit of a collaborative model up there. And we're looking at, creative ways. I think a lot of their programs are quite creative in terms of how they staff. So we're trying to work with that. And we've just started planning for St. John's. We're looking for a team to start there and start building that program. And then next will be Cornerbrook in the Western Zone. And we actually, we have a lot of interest for that zone. We have got some homegrown midwives who are partway through their training or interested in doing training and who are working on it. So it's all very exciting, but it does need to be quite staged, because recruitment has pretty much been our biggest challenge, but we're not alone in that. Every single jurisdiction is really trying to get more midwives. So that will be the key to midwifery access, is having midwives come or making our own, because that's been actually the biggest barrier. The funding is there and the interest is there, and people are keen to look at, how can we diversify our healthcare and increase our primary care providers? And so people are really open to it. We just need those midwives to come and start working, and then we'll have them in every zone. And then it's, hopefully from there, it just grows, and we'll see midwives in even more communities and in even more roles.
For sure, it'd be great to see it much more entrenched in our healthcare, and a lot more of a just a well-known option for people.
And that was a great question, Melissa. And I see, Sarah, you put in the chat that you often take students who are with an interest in midwifery. So that might be something for a health professional trainee who thinks they might have an interest, a way for them to decide if that's a path for them, perhaps.
There's
I'm one
also-
of the
I was gonna say there's
professional associates for the Center of Nursing Studies. So we often go out and do sessions with the nurse practitioner students, and have had LPNs and RNs and med students, and everybody reached out to us. So they're always welcome. And I would love to have more midwives, because I've done 500 MAPs in Gander and I still have 160 to go. So I need help.
There's also, we're working kind of thinking about creative ways of getting more midwives. We are I spent a lot of time in recruitment. We're trying to develop a good relationship with that Ontario bridging program, and people are very interested in doing their clinical placements in Newfoundland and Labrador. So that's very exciting as a stream for recruitment. And NLHS is actually offering their career development is offering for any NLHS employees who are looking at advancing their careers, having that salary like the package to compensate them through their education program and provide bursaries is now available, which is very cool. And that is actually posted right now for people to apply. They still have to get into the MEP or whatever program they need to take to be eligible. But we're looking at how can we've already got this great workforce. There is interest. People want to become a midwife. It's a long journey to becoming one, but we're looking at every single stream, and we've got MEP students now who are aware that they can come to Newfoundland and Labrador from Ontario, even just for a month. There's one in Carbonear not long ago, and just trying to increase our visibility with all of the people becoming midwives or people who want to become midwives. Because I don't think when you're in Newfoundland and Labrador, it's not necessarily on the list of professions that you're thinking about when you're like, what do I want to be when I grow up? It's still not really well known. So working on that. So kind of the next stage is getting to that next generation who are starting to move towards university and trying to plant this seed as an option, which will naturally come when we just have more midwives.
For sure.
A bit of knowledge mobilization work in your futures, I see. Is that something that you're doing with or thinking of doing with even like high school students, to say that this is an option or becoming an option here?
That generally is one of the roles. Like midwives do they do all this clinical work, but they do a load of like outreach to community too. And often practices will also go to high school, even if they're just providing some education around sexual and reproductive health and about midwifery. Those career, I think, Sarah, have you done a career day there? That's what midwives do everywhere, because it is something that we want people to know is an option for their education. But the midwife programs often do that. Like the midwives will get into their community and do that work.
Yeah.
And hopefully this healthy discussion helps with that bit of mobilization and outreach as well.
For sure. Okay, I'm looking at the time and seeing that we're at 1 o'clock. So we have reached the end of our hour. I want to thank you, Sarah, Brianna, and Chelsea, for leading us through a great discussion on today's topic. And for everybody who joined us online, excuse me, for listening and participating in our discussion. You will see a very short post-event survey on your screen after we end the webinar. We'd appreciate you providing us any feedback there. And just a reminder that the recording of this session will be posted on Quality of Care NL's YouTube channel in the next week or so. So you can check out recordings of all of our previous sessions there as well. So thank you again to everybody, and I hope you have a great rest of your day.
Thank you very much.
Yeah, thank you so much.